The actual function of the brain, not so sure yet. There's a lot of different theories about it, but when you talk about psychologically in your brain, a lot of people with insomnia, though not all, report that they can't turn their minds off. So this is not every patient I see, but I'd say a good 70 to 80% of the patients say that when they go to bed, it's like the stereo is playing at an 11 or 12, and they can't turn it down at all. So it makes it very hard for their body to down-regulate to be able to go to bed at night. And in those patients, they tend to then be more awake at night, so they'll toss and turn, they'll think more, they get frustrated. And when that starts to happen, you really don't sleep even more because you're making your body tense and your mind is getting more and more active. And you said sleep debt. So in general, there are patients with insomnia who, many patients with insomnia actually over-report the lack of sleep that they're getting. They are still having insomnia, but it seems worse to them than it actually is. So if they say they're sleep deprived, they haven't slept at all in 3 days, if we actually take them into a lab, most of the time we actually do see that they're sleeping on and off here and there. They might be little episodes of microsleeps or naps during the day, but they actually are getting a little bit of sleep. And we've looked at sleep diaries of patients with insomnia, and they'll say that they don't sleep for 1 or 2 days, and the body actually has a natural function after about the 3rd day to start catching up, and you get a little bit more sleep the 3rd night. And that's usually what I tell my patients. When they start worrying that they're not sleeping, I say the mantra to yourself, if I don't sleep tonight, I'll likely sleep tomorrow, and if not tomorrow, then definitely the 3rd, because our body has a way of naturally catching up. So there's a few different ways that we treat insomnia. The first thing that we always do is we look at the cause. So more times than not, but not every time, it can be linked to a medical problem such as menopause, cancer, chronic pain. It can be linked to anxiety and depression. Those are the more common causes. There are some patients who just have insomnia and they've had it since they were a kid and we don't quite know why. So when we look at the cause, we definitely want to treat whatever else is going on. But insomnia often becomes its own diagnosis, and that requires its own treatment. So if someone has chronic pain, we want to manage the pain, but we still want to treat the insomnia separately. So what we'll tend to do in our sleep lab is we do a thorough evaluation, and we usually have myself, who's a psychologist and a behavioral sleep medicine specialist. I treat the patients first. So we try not using medications initially, and we use something called cognitive behavior therapy for insomnia. This changes behaviors that people do in bed, none of the tossing and turning. I'll work on patients' thoughts about sleep. So I must get 8 hours of sleep tonight or I won't sleep tomorrow. That sometimes or I won't function tomorrow. That sometimes makes it very difficult for you to sleep at night. We'll work on relaxation strategies and also changing the times you go to bed. We'll actually make them sleep a little bit less for a few nights so their body's natural sleep drive starts to kick in. That is very effective in about 60 to 70% of patients who do it. 4 to 8 sessions, not even every week, it works for 60 to 70% of patients. The rates are just as good as all the medications that are out there, and the rates are actually better in the long term. The other option we have are medication treatments. So you'll have the treatments such as Ambien, Lunesta, Sonata, then we'll also have Rosarum, and for some patients we'll use benzodiazepines like clonazepam, things like that to help with the anxiety. Those are another option that we'll use. Sometimes we use them in combination with behavioral, sometimes alone. It really depends upon the patient.